Declan, it's winter in Australia and you can only get this sunshine and this view in one place, and that's the Gold Coast.
7 a.m. on a winter's morning. It's glorious, isn't it?
And what's our excuse for being here this time?
Well, so we're here for the ANZUP annual scientific meeting, the annual scientific meeting of our cooperative trials group, ANZUP, here on the Gold Coast. Perfect excuse to leave Melbourne in the middle of winter.
Perfect excuse. And the annual scientific meeting of ANZUP is a great conference. It draws a great crowd.
Yeah, it's exactly our shtick, isn't it? It's GU Oncology, it's multidisciplinary, we have industry involvement, patient involvement, nurses, all sorts of allied care, tackling not just prostate cancer, but all of GU Oncology, and led by ANZUP, who are just a great organisation.
Absolutely. I mean, it's still a young organisation, but it's achieved a lot in the last 14, 15 years.
Yeah, and look, many of you out there, our audience will be familiar with the name ANZUP, our cooperative trials group. They've put together and delivered some amazing trials, practice-changing trials over the years. ANZUP, of course, it was a fantastic trial we ran across these islands and a little bit overseas as well.
Therapy?
For metastatic therapy. Yeah,
huge.
The lutetium trial. Yeah. ANZURAD is coming probably in the next year or so. ANZUP, Louise Emmett read out last year. This is all ANZUP. They've been the sponsor of these great trials, and we love working with them. Ian Davis, who's the founding chair, I think, still ongoing chair of ANZUP, has led this organisation over the past 20 years to what it is now. And this annual scientific meeting wasn't there at the very start, but I think they've told us this is the 14th year of it.
Wow.
And you actually were co-convenor of the meeting last year, so you know all about this.
In sunny Melbourne.
Yeah, it's sunny Melbourne, yeah. And we did a podcast from there. That was fun as well.
We did. And so this time it's Aaron Hansen and Matt Roberts co-convening this year's meeting, and we are going to bring you some highlights.
We sure are. And we'll try and give you a flavour of the Gold Coast. And if you're listening to this on audio, please just flick on and have a look at this scene. And
it's incredible.
Yeah, it's like, people are down here swimming at 7 a.m. in the middle of winter. This is midwinter, of course, for us here in Australia. And it's glorious. It gives us an excuse to get barefoot on the sand down here and wander around.
Yeah, I definitely want to go and get my legs a bit wet.
And of course, all our conference highlights are brought to you with the support of our gold partner, Bayer in China. Bayer in China put specific funds towards us to help us bring you these conference highlights. So that's why we've got lots of video equipment up here. We'll be doing lots of podcasts and interviews with some guests and some delegates. And we've got some great
international delegates this time, so we look forward to bringing you all their latest research and thoughts and opinions.
Yeah, stay tuned. Let's go.
Let's go. I'm here with Professor Paul Nguyen, a radiation oncologist from the Dana-Farber Cancer Institute, known for being a radiation oncologist, but also for your shirts.
Oh, thank you, Renu. I'm so excited to be here on GUcast with you and Declan. This is crazy. I feel like I'm starstruck. It's a little bit.
We are thrilled to have you here, and this is not your first visit to Australia, is it?
Not my first visit to Australia. Right now, the wife and kids are out in Perth seeing the quokkas.
Wow. Okay.
But I've never been there. I've never seen those quokkas, but I hope to get to see them someday. But I'm loving it here.
Fantastic. Have you been to the Gold Coast before?
Have been a little bit, but not exactly to this spot.
Right, okay, very good.
Yeah.
Well, the most important question, tell us about your shirts. How do you decide the combination of shirt and tie, the color coordination? How do you do it?
Yeah. It has to be crazy.
Yeah.
So if it's not crazy, it's not good. And what my wife has found is that it needs to get, my unfortunately, almost like a drug addict, I've gotten a tolerance for it. So every shirt I buy now has to be crazier and crazier and crazier.
Right, yeah.
So it's getting a little out of control.
I think our GUcast merchandise will be too mellow for you.
No, but I'm such a fan of GUcast that I would wear it 24/7 if I could.
Paul, so radiation oncology. Let's talk about radiation oncology in 2024. What are you really excited about?
Let's see. 2024, I think...
Prostate radiation.
Yeah, prostate radiation. I think one of the things we're seeing in radiation, of course, is more SBRT.
Yeah.
I think it's great for patients. They can get done fast. I'm especially excited about this high-risk trial. We already had PACE-B for intermediate risk, and that works great for that.
Yeah.
The NRG GU13 trial is led by Dr. Karen Hoffman, and that's going to look at 5 fractions of radiation for high-risk prostate cancer. I think that's going to be great if we can do that for those patients.
Yeah.
The other thing I'm really excited about about is more personalization.
Yeah.
You know, we've got the Artera product out now that helps us differentiate which patients might need hormones and which won't in the intermediate risk setting. We've got Decipher out there that helps us personalize therapy. I think that's fantastic.
Yeah.
And the third thing I'm really excited about is some of these trials are going to read out soon. These high-risk trials that are looking at adding ARPIs, you know, Enzarad, Atlas, eventually the NRG GU009 and Dazzle High Cap. We're going to see these trials in the next few years. I think it's going to be great. We're going to know so much more about how to treat high-risk prostate cancer.
Yeah, absolutely. And what about PSMA PET? How much have you embedded it into your practice?
Yeah, I mean, unfortunately, we haven't been able to embed it in our NRG trials yet.
Yeah.
But certainly in practice, we're getting it for so many, pretty much reflexively for all of our high-risk prostate cancer patients. I know Australia is the hotbed of PSMA PET, Peter Mac especially, and you guys have been doing it for a decade, but we're starting to learn how to use it, and I think we're seeing it a lot more, pretty much standard for our high-risk patients, and doing it for many of our unfavorable intermediates too. Fantastic.
And Artera, you know, you've done it with some very high-profile radiation oncologists based in the US. You know, how has it been received, and you know, how much is it being embedded into practice?
Yeah, I think you know, Artera is kind of rolling it out right now, so it's not widely available to everyone yet, but I think for those sites that have been using it, and that's my site included, we have loved it.
Yeah.
Because you take an intermediate risk patient, and you know those borderline patients, you don't know if you want to give them 6 months of ADT or not.
Absolutely.
And if you get an Artera test and the biomarker is negative, all of a sudden you feel really good just treating them with radiation alone and knowing that, hey, you've spared them the side effects of ADT. So for that, it's been invaluable. Yeah,
and you gave a talk today on RNA expression and using AI-driven digital pathology to determine who needs treatment in high-risk prostate cancer. And I mean, that's really interesting stuff, isn't it?
Yeah, I mean, I think that's the future. The future is, you're not going to do one size fits all. Everybody gets 24 months of ADT for high-risk prostate cancer. I think it's going to be, you get a Decipher test, or you get some kind of Artera test. You know, Andy Armstrong just put out at ASCO last year this beautiful biomarker based on Artera that you can tell which patients need long course versus which patients might get away with short course. So I think it's going to be that kind of thing in the future. And we're trying to test that in the NRG, in the randomized trials. You know, we're testing Decipher in the high-risk space, and then the next trial that's going to roll out with Adam Olsen and Alicia Morgans is going to be testing Artera in the high-risk space. Yeah. So I think we're going to have that kind of proper phase 3 validation in the next few years.
And RP is all the talk these days, and I think these trials that are embedding RP into the radiotherapy regimen is really interesting. I mean, do you think we'll get to a point where we forego the ADT and it's a combination of radiation and RP?
See, that's a really interesting question because, you know, with the EMBARK trial showing that enzalutamide alone did better than ADT monotherapy, it certainly raises the question of whether we could drop the ADT. Yeah. And I think, you know, that's something that a lot of people are thinking about. And could you do that? Do you really need the ADT? I'm excited about that possibility, but you know, we don't have a trial yet that's looking at that, and I'm not going to do it off-label, but I think it's a really interesting question.
One for the future.
Yeah.
Absolutely. Paul, what else are you planning to do in the Gold Coast? When are you going to meet up with your family?
So tomorrow we meet up in Brisbane. They fly back from Perth. They've been sending me these great pictures of the quokkas. I'm so jealous of them. We're going to meet up in Brisbane for a beautiful dinner, and then sadly have to fly home to regular life again. But this has been just a dream.
Well, we are thrilled to have you, and thank you for joining us on GUcast, and we'll hook you up with some merchandise.
Well, thank you for fulfilling my lifelong dream of being on GUcast. Finally, I mean, I'm just a fan watching at home, and now I get to be on it. Oh my God.
Paul Nguyen, thank you very much.
Thanks so much.
All right, well, here I am with the wonderful Elena Castro. Elena, nice to see you again.
No, it's very nice to see you in this part of the world. It's my first time in Australia,
Your first time in Australia, I can't believe it.
Yeah, neither do I.
But not the first time for your family, because your husband David was here just last couple of months ago for the prostate meeting.
For the prostate meeting.
Yes, so both of you are friends of the podcast.
Yeah.
And you've already given you 2 talks for the meeting, so now you're on holidays.
Now I'm on holiday. Yeah.
And you're in no rush to get back to Spain. You're going to travel around Australia a bit first, aren't you?
Yeah. It's the first time I'm here, so I need to make the best of it.
And what are the things that you must see must do before you go back home?
I would like to cuddle a koala, see the Sydney Opera House.
Very good.
And the fabulous Peter Mac Hospital.
And our GU studio in Melbourne, maybe.
Of course.
Very good, Elena. You gave two wonderful talks in the translational plenary and yesterday. Mm-hmm. Tell us a bit about maybe the three take-home messages from your talks. You were talking about BRCA2 alterations and the impact of HRR mutations in metastatic castration-resistant prostate cancer.
Yeah, so I've been working for over a decade now on understanding the implication of germline inherited BRCA2 alterations. So we were able to demonstrate that these are associated with poor clinical outcomes, and we've been trying to characterize those tumors, what it is that these tumors have that make them behave the way they do.
Yeah.
So we identify different genomic events. Other researchers also identified that there is a global hypomethylation, and there's some discussion about whether the intraductal histology could also be associated with these tumors, and also these are also features associated with poor clinical outcomes that could contribute to this bad prognosis.
Yeah.
And then we expanded, once we understood the implications of inherited BRCA2 mutations, we tried to understand the implications of tumor-acquired BRCA2 alterations, but also alterations in other HRR genes.
Yeah.
That was presented at ASCO last year, has already been published, and we learned that these somatic BRCA2 alterations are also associated with poor clinical outcomes, and we are slowly understanding the implications of other HRR genes. For instance, it seems that CDK12 or FUNK-A could also be associated with poor outcomes, whilst alterations in ATM may not.
Wow, big space here. And what about PARP inhibition? Because in these selected patients, PARP inhibition seems to be the future. We chatted briefly at APCCC about this. Has anything changed since then?
Not really. No, since last APCCC. I think the FDA published this meta-analysis looking at where they merged data from the three trials investigating ARPIs and PARPIs. And the conclusion is that there is a clear benefit for patients with BRCA1, BRCA2, PALB2 alterations, even for CDK12, which we don't understand very well. And it seems that ATM and TEC2 may not predict response to PARP inhibitors. But there are several trials still ongoing with different agents in the MHSPC space. Trials in the localized disease are also being conducted.
Yeah.
So nothing new in the last 3 months, but we need to stay tuned because
absolutely
new things will arise.
Such a fascinating space, and I'm really interested in that, that synergistic effect between PARP inhibition and ARPIs. But also, what about the role of lutetium PSMA in combination with PARP inhibitors?
Well, we have some studies also looking at that, and what we know so far is that this is feasible and is well tolerated, and there seems to be good anti-tumor activity, but I guess the studies are still early phase trials and we need to wait a little bit.
Fantastic. Elena Castro, always such a pleasure to chat with you, and we are looking forward to welcoming you to Melbourne, to Peter Mac and to the GU studio soon.
Yeah, I can't wait.
All right, so we do have a fantastic lineup of international guests at this year's ANZUP, and I'm here with one of them, Professor Ravi Kanesvaran. You are the chair of the Division of Medical Oncology at the National Cancer Centre in Singapore.
Yes, I am, Renu, and thank you for having me on GUcast. I've watched it many times, and this is going to be my first experience, being interviewed here.
Well, we had a failed attempt at ASCO GU, didn't we? You had gold to say, but unfortunately I didn't turn the microphone on.
It became a silent movie, but
That's
it's fine.
right.
We have the chance to.
And this is not your first time in Australia. What about the Gold Coast? Is it your first time here?
First time Gold Coast. So,
yeah. And what do you think of the weather? Beautiful,
awesome.
right?
Yeah.
So you kicked off the conference really in the first plenary, and it was called "What's Making Waves in GU Oncology." And it's amazing. There's so much creating waves out there. And we had a talk on testers, we had a talk on prostate, but of course you delivered a riveting talk on what's making waves in bladder cancer. And we're all looking for treatment intensification in the perioperative, adjuvant, adjuvant setting, and of course that's where you started your talk. So, can you tell us about what's out there in terms of adjuvant and perioperative treatment for bladder cancer?
Looking back at adjuvant trials, we have 3. So we have the IMvigor10, we have Ambassador, and we have Checkmate 274. Now, amongst these trials, 2 of them, Ambassador and Checkmate 274, showed a positive disease-free survival benefit for patients who had resected muscle-invasive bladder cancer, and unfortunately, IMvigor10 was a negative trial. Right. Nevertheless, there was some very interesting post-hoc analysis, which I'll talk about in a short while. Now, let's look back at the 2 positive trials. With regards to Checkmate 274, clearly there was a benefit in terms of disease-free survival for patients who were on adjuvant nivolumab, given at 240 milligrams 2 weekly for a year, right, versus patients who were on placebo.
Yeah.
Now, of course, one of the challenges in the trial is that we've yet to see an overall survival benefit. Similarly, Ambassador showed a benefit for pembrolizumab over observation, again for patients who had resected bladder cancers. Now, the difference in these trials, one thing is that in both these trials, a proportion of patients had neoadjuvant chemotherapy, and then subsequently had high-risk features, post-op, and subsequently were randomized. And these patients, some patients who did not have neoadjuvant chemotherapy, declined adjuvant chemotherapy, hence got onto this trial as well. So now we have these 2 drugs. IMvigor10 is interesting. Although it was a negative trial, post-hoc analysis seemed to show that patients who were ctDNA positive, right, means they had some MRD or minimal residual disease, seem to benefit from atezolizumab.
Right.
So perhaps that's a good biomarker space that we should watch very closely, not just in adjuvant therapy for bladder cancers, but perhaps adjuvant therapies in other cancers as well.
Yeah, very interesting, isn't it? So 3 adjuvant immunotherapy trials, 2 of them that reached a disease-free survival advantage, and 1 which did not, but still has some interesting aspects to it. Now, how do you bring that into practice, Ravi? Because adjuvant chemotherapy is quite established now for high-risk bladder cancer. How do you bring this evidence into clinical practice? I mean, you are going to tell us soon about a trial that we're hearing may have reached an OS benefit, the Niagara trial. But right now, just with these 3 adjuvant immunotherapy trials, how do you decide if you had access to all of them?
Right. So in Singapore, we have access to 1, which is nivolumab. The patients that I would choose, firstly, patients who've had neoadjuvant, chemotherapy for sure, and subsequently had all these high-risk features. Number 2, again, when you look at the subgroup analysis, patients who had upper tract tumors didn't seem to benefit. So perhaps just focus on bladder cancers. And the third point I'd like to make is clearly those who were high expressors of PD-L1. In the case of Checkmate 274, that would be a PD-L1 expression of more than 1%. So in fact, the approval indication in Singapore is for patients who are high PD-L1 expressors, and they get access to adjuvant nivolumab. Now, coming back to what you mentioned about Niagara, so an interesting study. So this is durvalumab, right? It's a PD-L1 inhibitor plus chemotherapy, followed by surgery, and then a continuation of another 7 months of durvalumab thereafter. It's a perioperative approach, and top-line data, it did meet its primary endpoint of overall survival benefit. So I think we're all waiting with bated breath to see, what the actual data is going to show us. So this may actually again change the landscape, hopefully for the better.
So this is AstraZeneca's phase 3 Niagara trial that hopefully will read out soon, and we'll see those results. Let's move on to the metastatic urothelial cancer setting, and again a lot to change in recent years, and now with EV-Pembro really kind of hitting first-line treatment. Tell us about the latest data there, and again, now you're spoilt for choice.
We are. I think the EV-Pembro study, the EV-302, was practice changing, right? And when it was presented, I mean, people were so excited, right? But then again, when we use it in clinical practice, there were concerns. Specifically in Asia, when I talk to my colleagues in the region, I apologize.
We're going to, don't apologize.
Because,
this is the bell getting everyone back into the plenary hall, but let's keep going. This is what happens in a conference.
So I think one of the challenges has to do with toxicity, EV toxicity, namely 3 main issues: the rash, the neuropathy, and hyperglycemia. And the rash being quite a big issue that we deal with. Now, at ASCO this year, they presented the QOL data. right? So this was using the EORTC.
This was Shilpa Gupta's data, yes,
C30.
very nice, yeah.
Exactly. So this literally asks patients about how they feel, how well they felt over the week, and so on. So regarding their health status. And in that data, it was pretty interesting that patients on EV had a deterioration only in the first 3 weeks, and by week 4, they had come back to baseline, right? Compared to chemotherapy, where the deterioration ran right across their period when they were on chemo, and the improvement only came about after they completed chemotherapy. So this was, I guess, not what people thought we would see, because we thought, EV is pretty toxic as well, and usually the rash comes in at a median period of about 10 to 12 days. But surprisingly, that's about the time when patients started seeing an improvement. So interesting data, thought-provoking. The other thing that came out was dose. There's clearly a dose-response relationship. Now, with a lot of us who have to dose reduce because of toxicity, I think it's something to keep in mind. We want to also keep that dose intensity going for as long as possible.
And what is your access like in Singapore to these drugs in the metastatic setting?
So EV is approved in the second, third line onwards. However, EV Pembro is not approved yet. So patients can pay out of pocket to get it on an inpatient basis, but it's not on our cancer drug list, and neither is it reimbursed.
And in your opinion, if a clinician has access to everything, how do you again decide between EV Pembro as first line or chemotherapy and maintenance avelumab? Is it to do with quality of life and what dose they can tolerate?
Absolutely, it's a great question, and I think because we have so many options, again, all of us will look at efficacy as being, the primary endpoint of choice in terms of how we would choose treatment. Now, if you go by that, then in the EV302 trial, about a third of the patients did get avelumab, and it seemed like the EV Pembro combination is probably still better than going about chemo followed by maintenance avelumab. And with that strategy, you're still looking at responders to chemotherapy, while with EV Pembro, you can continue using them. The other thing is about cisplatin ineligibility as well, because with EV Pembro, you could use it on cisplatin ineligible patients. Right. Now, the third point I want to make is not all patients may be fit enough for EV. And most recently, Enrique Grande and colleagues had come up with some suggestions on patients who potentially may not be suitable. This includes patients who have poor sugar control, HbA1c that's more than 8%. I think there were like 4 criteria there, and you fulfill 2 out of the 4, you would probably not be EV.
So that's interesting. So I think that's why in your flow chart I saw those patients who were cisplatin ineligible. In fact, the first line of treatment for them was IO monotherapy rather than going straight to EV, because they're unlikely to be a candidate for EV treatment as well. So Ravi, I find the concept of ADCs or antibody drug conjugates, which EV Pembro is, very interesting. Are there any new ones in development? Can we expect others?
So there are a bunch of new ones in development. I think firstly the anti-HER2 or the HER2 targeting ones. There's disitamab vedotin or DV, right? So this is a drug first developed in China and now of course taken over by Seagen and now most recently Pfizer. So there's a phase 3 trial that's ongoing right now. So it's DV plus Pembro in the first line, although they're a bit behind, and it's a selected group. So it's for patients who have immunohistochemistry 1+, HER2 1+ and above. So that's not going to be everyone, but it's going to be
very select group of patients.
A relatively large population of patients. So that's one. Another drug would be TDXD, which is everybody's pretty much familiar with, trastuzumab deruxtecan, and that particular drug, there was a pan-tumor study called Destiny Pan-Tumor, and in that study there were 41 patients with bladder cancer, and there was a benefit, right? So the company has applied for pan-tumor approval, which they likely will get.
As such, approval,
so right across numerous tumor types. And of course there are anti-TROP2 ADCs as well, like sacituzumab govitecan, which many of us in the GU world are familiar with because we can use it after EV, for example.
Targeted therapy really is the way forward, isn't it?
Yeah, absolutely.
Now, before I let you go, Ravi, we must talk about ESMO Asia, because ESMO's coming up for sure, but ESMO Asia, big deal. It's in Singapore this year. I'm looking forward to attending. What can we expect for GU Oncology?
So I'm glad you agreed to be part of the GU faculty, and it's an honor to have you there. ESMO Asia basically is one of the biggest I would say, multi-cancer conferences in Asia. Has been held in Singapore. This is our 10th edition. Wow. And on average, we get roughly about 4,000 delegates right across from Asia. It was something ESMO started because 25% of ESMO membership are from Asia and Australasia as well. So pretty exciting, GU program. You're clearly aware we're looking at prostate and non-prostate tumors. Yeah. We've hit a record number of abstracts this year, and now I think the faculty, you'll be reviewing those abstracts. I think soon. They've given you a deadline of about a month or so to. And if I'm not mistaken, we had 300
there you go.
Submissions.
And unlike many major conferences, Singapore's just a hop and a skip from Australia, so it'll be
looking forward to see as many folks from this part of the world, Australia, New Zealand, and other parts of Asia as well.
Well, Ravi, thank you for your amazing contributions here. We're looking forward to your other talks, and I do hope you get out to the beach soon.
I hope so too. Thank you. Thanks, Renu.
I'm here with Dr. Cristiane Bergerot, a psychologist here at the ANZUP meeting. Cristiane, you're one of our international faculty. Welcome. Great to see you.
Oh, thank you so much. It's a great pleasure to be here.
And so you're from Brazil?
Yes, from Brazil.
And your husband is here with you. He's on the faculty as well, Paulo.
Yeah, he's with me here, and also our daughter with 5 years old to get our life crazy.
Exactly. Welcome to Australia. I presume you're having a little bit of time to trip around.
Yeah, we'll try to walk around and to know a little bit more about the city and to go to the zoo.
Exactly. You've come this far. So you gave a really fantastic talk just now at ANZUP about a big area of interest of you, and this is mindfulness for patients with metastatic renal cancer. You've done some very nice work on this app which delivers this. But before we talk about the intervention that you described this morning and the success of it, tell us a little bit about this population of patients. It's patients with metastatic renal cell carcinoma who are on immunotherapy in particular. So there's an unmet need, isn't there, with the way in which they experience being on that treatment?
Mm-hmm, sure. I think it's, so at least based on our previous studies, we have noted that these patients report a high rate of anxiety and also fear of cancer recurrence, since they are dealing with a new type of treatment that for sure they have the chance to have their disease cured, but we know that it's just a small proportion of patients, and for sure if the disease progresses, they will need to change the treatment. So usually we're dealing with patients with a lot of anxiety and sometimes with some depressive symptoms too.
Yeah, that's quite significant, isn't it? And do you think we as clinicians working in oncology don't manage that or don't anticipate it very well? I mean, we do get focused on how are these, how bad are the metastases? Are you responding well? What about the toxicity, the sort of stuff that gets reported in the journal? But maybe we don't do a good assessment of their anxiety and distress.
Yeah, I would say that we also have the challenge that since most of our patients are male, they have a hard time to share with us what they are feeling and what they are experiencing. And usually they tend to focus more on numbers or even on side effects, or in some ways that they will feel that they have some control of their disease.
So then tell us about mindfulness in general as a strategy for dealing with these conditions, these symptoms for patients, and then a bit about this lovely app that you described this morning.
Yeah, I think the mindfulness is a great resource. We have been talking about this type of interventions for a long time. I think a great addition was some data from guidelines from ASCO showing that the mindfulness could be a great resource to manage anxiety symptoms and also fatigue. So we have a dual main effect if we use this kind of intervention with our patients. But we started working with us maybe some years ago, like in 2020, when we were in the COVID. So we need to find some remote strategies to give some support for our patients. And it was when we come up with this with this app that was based on a 30 years work from Dr. Elena Castro, and she has translated these intervention in an easy format for cancer survivors. And then we decided to test among our patients with metastatic renal cell carcinoma.
And you, Dr. Nelson was a mentor of your thing, along with Monty Pal at City of Hope.
Yeah, so Dr. Linda also was my mentor, and Monty Pal, and we were able to run this study in the United States and also in Brazil.
Fantastic. So then you showed some really interesting data this morning about this app. So tell us a little bit about how it worked and what the success was.
So yes, eligible patients were encouraged to engage in 20 to 30 minute activities over a 4-week period. And basically, during the short period, we were able to see a high rate of adherence to the app, and also showing that this type of intervention is feasible and also acceptable by our patients. And notably, most of our patients have reported improvement in their emotional symptoms, in their fatigue, and also in their quality of life.
And it's great, it's self-directed, and you pointed out earlier that it was mostly men, it's mostly men with metastatic renal cell carcinoma, and you did also point out that us men are often not good at that. We're maybe less likely to go and visit someone like yourself or take time off and go to a clinic, but maybe if there's an app on the phone, so it's more self-directed. So that seems to be a key part of this for us, is that for this population who may not reach out and so on, that they are being more self-directed, might be more comfortable, and it was really encouraging. So you had rates of adherence of up to like 75% 4 weeks or 6 weeks later, I think. But that's very good for this type of intervention, isn't it? People are engaging with it, 30 minutes a few times a week. So if the majority of people are still engaging with it, it must mean the formula is working. People feel comfortable with the intervention.
Yeah, I think it's for a short period that they need to do it. So I think it's feasible for them. Yeah. So even it's not they do not need to go to somewhere to get this kind of intervention, or they do not need to spend like 1 hour or 2 hours doing some type of activities. They would just need like to listen and try to focus on what they are listening and also to practice some exercise. And I think it was maybe potentially the secret of this type of intervention.
So I've two final questions for you. One is, a lot of our listeners and viewers are patients who may be out there with advanced kidney cancer or indeed advanced other cancers. So the two questions I have is this intervention, will it be more widely available? It sounds fantastic to have an app-based thing that people anywhere could access and improve their quality. So is it going to be available outside trial?
So it is already available.
Great. Yeah.
So it is. So everyone who are interested can try to find it in their app.
What do they search for? And we'll put it up on the screen.
AMDTX.
Yeah.
So it is the
Type
name of
AMDTX in your app store.
Yeah. And they have options for mindfulness for different type of disease, also for patients with diabetes and also with other. And if I'm not wrong, they have also developed during the COVID something for patients with COVID. But the one for patients with cancer was the only one that was developed and devised by Dr. Linda Carlson.
That's fantastic. And the second question, you've sort of answered it, is what about other cancers? You talked at this conference about kidney cancer, but I know many of our listeners out there have advanced prostate cancer, for example. Mm-hmm. Is there a role for mindfulness and in specifically these apps for these patients? They've got the same sort of fear of cancer concerns, but they also have treatment-related side effects that may cause anxiety and depression.
So it is not disease specific. Yep. So initially they were developed for patients, for survivors, and we have noted that also patients with cancer can benefit from this type of intervention. And I would also highlight the benefit of this intervention for fatigue, since I know that most of our patients struggle with, and it's really hard for us to improve their fatigue, also to be prepared for the new treatment. So I would also advocate for them to use it in order to improve their fatigue.
Absolutely. Great. Well, I'm sure we will see some of our patients do that. And thank you again for coming. And I've known you through Twitter for years. Myself and Renu have followed you. You've always been very entertaining and educational, watching your Twitter feed back in your day, working with Monty Pal and all that. So lovely to meet you in person, and thank you for coming to Australia.
Thank you.
Okay, so we have had some very cool pathologists on GU Cast, and this one is no exception. Welcome to the podcast, Associate Professor Fiona McLean, a fantastic pathologist from New South Wales and part-time stand-up comedian.
Well, thank you for having me, and thank you for laughing at the jokes at the right time.
It's been wonderful to have you here, and different to the other conferences, you're not here to tell us about the different variants of renal cancer. You're here to tell us about your involvement with AI.
Yeah, I've actually been working with an Australian startup company in AI for the last 2.5, almost 3 years now, making products for pathologists to help increase efficiency and pick-up of tumours and help with classification.
That's incredible. And how did you get interested in this?
I think, with any sort of career, you're kind of looking forward to, where your career is developing, where your profession is going, thinking about, where will pathology be in 5 years, 10 years, 20 years, And I'm somebody who likes to be on the front foot. So, rather than receiving changes and having to adapt to the changes that are coming through, I would rather see the changes that need to be made and then actually go and make them in the right way, be able to say, okay, well, we are going to change. This is something coming for our profession. So why not take the bull by the horns and actually do things that are going to be helpful to pathologists in general?
Absolutely.
Otherwise we can have data scientists or somebody else bring us a product that maybe just doesn't.
And then
do
you
what
have to
we
get
want
used
do.
to
Right.
it and somehow fit it into your practice.
Yeah, you still have to
Absolutely.
do that, but maybe having something that actually does what you need it to do, like actually being fit for purpose, and maybe actually has some secret little extra bits and pieces in there that only a pathologist would know would be beneficial, right?
So tell us a bit more about your work, because we had this fantastic talk from you. It was our entertainment last night at dinner, and you brought up 3 key things that I want to focus on. The first one was AI assistance. Tell us about how you've sort of worked into that.
Yep, so that's actually the sort of products that we're working in right now. So we've just been working on a prostate product, which should be available for release very soon. And that would assist a pathologist in their day-to-day tasks of diagnosing prostate cores and TERP specimens.
Right.
And, you can use these products to do things like help with diagnosis, help with quantification. AI is actually very good at quantification, and, pathologists, counting and measuring and counting brown dots, it's really not the exciting part of pathology. We like to diagnose things. You go into pathology to make diagnoses. You don't go into it to count dots or to measure millimetres or, So it can take out the sort of tedious, unexciting parts of the reporting, steps, and it actually leaves you to be able to do the more exciting things like, diagnose what you're looking at and, find the things that are there. Right?
And how much of your work has now been taken over such a tool?
So I've been working in AI for half a week now for almost 3 years.
Wow. Okay.
So it does take a long time to make good models. And this has been part of the the processes. It's actually been a fairly long process because we want a really good model. But I think in Australia in labs it's really not come in just yet because we're still waiting for this digitisation phase, and I think labs are turning their eyes now to digitisation and how that can actually be done effectively and efficiently, so that then that frees up the material to be able to be imaged and then used. To use the AI models, you really do need to have the sort of material digitised in
Very
some format.
good. And the second thing you focused on, Fiona, was something that we're quite familiar with, which are large language models like ChatGPT.
Yes.
And I'm interested to hear how you've sort of incorporated those big channels into pathology practice.
Yeah, so we haven't yet. I think those things are less well regulated. So, a medical AI device actually needs to go through, regulatory controls. And so, you can feel a lot more reassured that a product on the market will have had to have stepped through all of those things. With the large language models, they're not so well controlled. I mean, anybody can use it. You can get on and have a go, and most people have by now, had a go with some of these models. There are bigger issues with privacy and, data sharing, with them. And so I think we need to be thinking carefully as doctors about how we're going to be using these models. There's been proposals for being able to, use it for many things like summarising patient details or, being able to even summarise the literature for you. But there are traps. The models hallucinate, so they actually, will make up things that aren't true. So as a doctor, you need to be fact-checking and being careful because it can look quite plausible. You look at something and you read it and you think, oh, yeah, that sounds great, but actually it's maybe not completely true. It might be 90% true, and then, that we have to find the 10% that's not there. So you have to be careful. I think they're very useful. They're really great at writing a talk or something. It gives you a nice structure. But it's if you stood up and just read a talk from, a chatbot or a large language model, I think you would pick that up pretty quickly.
Absolutely.
So they have a role, but I think the role just needs to be carefully considered. And you're still the doctor. You're still in charge of what you're doing. You still have your patients' concerns at heart, and you still, constrained by privacy regulations and by all of those things that you need to be careful about for good reasons.
Yeah.
So,
and all good things to remember, because you did give some very funny examples of where it went wrong.
Yes.
So important to stay alert when it comes to that. And the third thing is AI agents.
Yeah, so they're a newer thing that people are moving into this now, where you can actually have an agent which will run things for you. So, just as a practical thing, for doctors, I'm always busy and I never get the car serviced when I need to get it serviced, and all of that sort of. My car service light comes on all the time. Your service is coming up. Oh, your service is now overdue. Right. Okay. Good. But help you with just planning things, and I'm sure in that space, as people use those more and more and develop different ways of actually utilising them, there'll be more and more ways where we'll be able to find that we can actually use an assistant to be able, almost like having your own PA, right?
Yeah, absolutely.
But, an effective one.
Right. Now, one of your talks, and you haven't delivered this yet because that's tomorrow, is learning to surf. Yeah. Can you give us a little snippet of what that might involve?
So the theme this week has been about riding the wave, or riding the
what's making waves.
Yeah, what's making waves? And harnessing the waves. And how do we harness those waves when we see them? And I'm actually speaking about career tomorrow. Okay. And so I actually used to live with these surfy guys, and on a Saturday morning what we would do, we'd go to the beach, we'd park at the beach up high, and we'd look down and we'd look at the waves. And we'd sit there for 5 minutes, and we'd go to the next beach and we'd look at the waves, and we'd sit there for 5 minutes. Go to the third beach and we'd look at the waves. Then go back to the first beach, and then they'd go out and surf, right? Back at the first beach. And they'd be out there and they'd still be looking at the waves. So the thing is, I think with career, I think when you're early career, you don't realise there are so many waves coming. Yeah. Like there are so many opportunities, around us. Part of it's being aware of what's around us and being aware of how you find opportunities. Yeah. So a lot of opportunities actually come from different directions that you're not anticipating. It's from communicating to people and spending time, at conferences, and, just actually meeting your colleagues on I think a more personal level. Yeah. A lot of career opportunities come from recommendations. People have worked with you before, or they've heard you present and they ask you to go and do another talk, or, that sort of thing. And I think the important thing is to not try and jump at the first wave, right? There will be many waves coming, and you need to pick your wave. Yeah. Right? Pick the waves that actually bring you joy. Don't just do the waves that are going to, maybe put you forward or push you up, because they can be tedious and you get stuck in those ones. You really want to choose the ones that are going to be enjoyable, because, we're not really looking forward to 10 years' time where we're going to be with our career, because you're here today. So you need to enjoy today, and you need to be actually doing something that's fulfilling you now, not thinking about in 10 years.
Very wise words, Fiona. And, one thing that people will always ask of someone who's in AI is, will AI replace doctors? And you had a very good answer for this.
Yeah, so I think it's quite clear that, AI won't be replacing doctors. I went through a number of times where AI had, missed the plot, and you really need to be there as a doctor looking after your patient in whatever capacity it is and whatever your tool you're using. So, AI won't be replacing doctors, but I think doctors using AI will be replacing those not using AI.
Very nice. And Fiona, you are the immediate past president of the International Academy of Pathologists. So you're in a perfect position really to take this to the rest of the body. What's the uptake been like for pathologists so far in AI, and do you expect that to increase and improve?
I think if you look at radiology and pathology, because we're image-based, it's been easier for AI to start as a much more realistic tool, to be able to conceive how we would use it and for products to actually be made. So products are coming out now. They do take a long time to make a good product, but they are available on the market. And I think, in Australia, it's the digitisation that's actually the slower point. Yeah. And I think once we've got that on board, certainly AI will offer, ways to actually enhance the job that we do. And I think that comes on board at the same time with a changing in demographics in the world. Yeah. If we look at Australia, our population is ageing. If we look at the number of prostate cancer cases, they're increasing, and they're only going to increase. Yeah. and so therefore the workload for those of us that are in the system is actually going to be much higher. And if you look at how long it takes to train, right? A person, not an AI model, like a person, how many years you have to train. If you suddenly start losing significant numbers of your cohort because the baby boomers are beginning to retire, and then you're getting increasing numbers of specimens, you're in this sort of
real mismatch,
perfect storm of not having enough resources to be able to carry out the tasks that you need to do.
Yeah.
And I don't want to be there increasingly later and later every evening, coming in on the weekends. If something else can help me and improve my ability to detect something and also improve my efficiency, then of course, it's a no-brainer, I think. Yeah.
Fiona, always lovely to chat with you. I'm looking forward to the rest of your performances during this meeting. We should go and watch some waves together.
Yes, that sounds very good.
So Declan, we've enjoyed sunshine, we've enjoyed science, we've enjoyed some collaboration and networking, and it's all thanks to this guy. Matt Roberts, co-convenor of ANZUP, along with Aaron Hansen. Congratulations on such a great meeting.
Thank you very much, and thanks for being the media partner and covering the meeting with your excellent podcast. And I'm a bit of a fanboy, and I'm proud to be here. So,
there you go. Look at that.
There we go.
The bucket hat suits you,
If you're
Matt.
not watching on video, he's got his GU Cast beanie, the latest series of merch from GU Cast. Oh, that's great, Matt.
Well, this is a bucket hat, but we will pass on a beanie.
Oh, sorry,
He lives in Queensland, though,
that's right.
so,
It's a bucket hat.
Yeah, a bit beanie in Queensland. That's a very Melbourne thing to do. Yeah.
So Matt, you're a urologist like us. You're an associate professor, and so this is great to see more and more urologists coming to this GU Oncology meeting. We've enjoyed coming for years, and you co-convened it last year, Renu, as well. But what's your take on it as a urologist putting a meeting like this together?
You're absolutely right. I think urologists we're the centre of GU Oncology, much to the other specialists' dismay. We see these patients right from the start, right to the end. So I think we should be the centre of these meetings, coordinating the care, at all aspects. And one thing we've really tried to do with this meeting is try to incorporate all aspects, which is impossible, but we've given it a good go, and particularly having consumer involvement, diversity in all aspects, and covering many things so that people can consider the whole patient journey and the bigger picture as well. Our session this morning on value, really tried to consider the whole picture.
Yeah, I've always been impressed at how ANZUP really has that multidisciplinary feel to it, but it can be quite a challenge for urologists to see the value in a meeting like this, and I think it's been impressive how over the years the involvement of urologists, not just in attending but also being involved and chairing sessions and giving talks, has really kind of been on the rise.
It's so important because we're the first person the patient sees. So if you say, there's option of radiation, potential novel hormone therapy, these new checkpoint inhibitors, et cetera, we might be able to give a brief explanation but go see the medical oncologist for the detailed explanation. But if we know nothing about any of that, how are the patients to know what to do?
And the other encouraging thing to see, Renu, is ANZUP does support a lot of research as well as coordinate research as a cooperative trial group. And they've always been very proactive at trying to get urologists involved, and they've funded quite a lot of surgical-oriented research over the years as well. So that's a good thing for listeners out there to think, okay, ANZUP, look toward, they have some really, really good awards, and the below-the-belt awards and education fellowships and others. So, it's great to increase the visibility among urologists, I think, in particular.
And also, through those fellowships, as you said, that allows people to attend the meeting who may otherwise not be able to. And a really important group of that is trainees, because the education of GU Oncology, it's a long process to learn it all, and it starts as a trainee, So we'd love all trainees to try and come to the ASM, but also ANZUP has a lot of other activities. So there's the rapid fire workshops and those kinds of things. Preceptorships.
The Ideas Generation Workshop, I think, is a
Exactly.
fantastic initiative. So, if you have an idea for a research project, bring it along. You can get funding, you can get ideas on how to make it better.
From these smart trialists, it's really valuable. You might have an idea, but I don't know how to put together a protocol. But come to these workshops.
Absolutely, and it's that the feedback in those particular things is not just about ideas. It's about how do you actually make it happen from an idea to execution, and that part is just so important. So it really covers many aspects, and that's throughout the year. So if you're not involved in ANZUP, we'd strongly encourage you to become involved.
And the other great thing about the amazing trials that ANZUP have funded and run are the databases that are still existing. And these databases continue to bear fruit, don't they? Yeah, they continue to deliver. And, you can often get a great idea and come to a well, thought out, well-produced database, and you've got a lot of your starting material right there.
And ENZUMET is one of the ANZUP trials is a good example. Here you are years and years later, and it's still reading out translational data, because unlike many other commercial trials, they do really fund the translational research, and you see it reaping the rewards years and years later. And ANZUP, it's a free organisation. You just sign up for free. You just need to send off an email, and you get a bit of support email here and there. So no excuses.
Yeah, and good point on the databases, in that we really also encourage our urology colleagues to become involved in that. So we have the cystectomy database, we have the upper tract database, there's a penile cancer database coming, so many registries like that that ANZUP are supporting, and so we'd really encourage that involvement.
And the other thing, so much I love about these ANZUP altogether, but these meetings especially, is because it's sort of still got a small meeting feel to it, you really get to know some of these international key opinion leaders. If you go to the AUA or the EAU, you see them on stage and that's it, but we get to have dinner with them, we get to hang out with them, we get to... it's been really fun.
Yeah, how often do you get to have drinks and do dance-off with Paul Nguyen?
As we saw.
He showed us his moves, for sure.
That's it.
Well, it was great. Well, congratulations again, Matt. It's been a great meeting, and to everyone at ANZUP for putting it together. And we've enjoyed being here and bringing you a few highlights.
Absolutely.
Thank you very much, GU Cast.
No way. Cheers.
What a great couple of days.
I really enjoyed that.
Do we have to go back to Melbourne? Remind me why we don't live in the Gold Coast again.
It's only a couple hours flight up here as well, it really is.
Yeah.
And the whole stretch, by the way, over our shoulder going up for another about 3,000 or 4,000 kilometres is basically beach up to the north of Australia. Yeah. And it's amazing once you come up here to beautiful Queensland, and the farther north you go, the more tropical, it gets proper tropical. Yeah. An hour or so north of here, and we're always happy to come here in the winter.
And all our guests had such a fantastic time, and it was really fun to catch up with them.
And thanks to them all for giving us time to chat to you all on GU Cast. We love these quick snapshots. You can find more detail elsewhere for specific conference highlights, but we love bringing you a flavour of the meeting and our international guests, so hopefully you all enjoyed that. And do watch out for our dedicated testicular cancer episode with Rob Hamilton and Ben Tran. Yeah, because we didn't cover it in this podcast highlight, but it was such a key part of the meeting, and there was such a great guest with Rob Hamilton from Toronto being here, that we actually sat down for a more extended discussion with himself and Ben Tran, one of our advisors here on GU Cast, about testis cancer. He talked about three waves, three great waves. Big waves. On our three big waves since they cured testicular cancer. So they say. But look, that's a great episode. We'll send that out very shortly as well. And we don't do enough testicular cancer, but this is a cracker. And I think that's what I loved about this meeting. There was real focus on non-prostate malignancies, and that was really good. Refreshing. Fresh air. Yeah. It really was, wasn't it? So that's it. Thanks again to Bayer China for supporting our GU Cast highlights, and we'll be back soon with more.